Okay, we're ready to get started. Thank you so much for bearing with us. We're all learning a little bit about Zoom these days and a little bit of a technical issue to get started, but we're ready to go. So hi, I'm Josh Knights. I'm the Director of Partnerships at the Sustainability Institute at The Ohio State University. On behalf of the College of Public Health, the Infectious Diseases Institute, the Sustainability Institute at Ohio State, we're pleased to welcome you to this discussion with Professor Mark Weir on understanding and altering the COVID-19 curve in Ohio. Among other things, Mark and a number of his colleagues have been helping Ohio's leaders assess the steps needed in reopening the state and modeling the risks to healthcare workers. Mark sits in the College of Public Health and is director of the Ecology, Epidemiology, and Population program of the Infectious Diseases Institute. He's also a core faculty member of the Sustainability Institute. Now, before turning things over to Mark, I wanted to cover one piece of housekeeping with all of you. We're going to keep you on mute throughout this 1-hour program. If you have a question for Mark, please use the chat feature. I'll help Mark by teeing up some of your questions after his presentation. And now, let's hear from Mark.
All right. Thanks, Josh. All right, so you should see slides now. And it's kind of hard not to fall into lecture mode when I'm going through slides anymore. So it's an interesting adjustments. Thank you very much. This is going to be quite interesting to go through what we're doing. So we'll move in right away to discuss what the overall situation is and then move in from that. So everyone's already heard of COVID-19. Obviously, at this point, there's no way of getting away from the news, even if you try, like I am on social media, just trying to isolate as much as possible. It's caused by a viral agent called SARS-CoV-2, so it's a coronavirus. As it causes a severe acute respiratory syndrome. So that's where that name comes from. COVID is coronavirus infectious disease 19 from 2019. So it starts in the back of the nose to the back of the throat area. So if you think about it on a profile view, kind of back here, but inside onto your nasal passages. So that's really where it starts. The test for it is really unpleasant because of that. They have to stick the swab down your nasal passage to be able to touch kind of like the back of your throat. So it's a relatively unpleasant test, but the disease itself is even more unpleasant overall. It replicates rapidly, so the virus itself replicates quite rapidly, and you can aspire it down into the deeper regions of your lung. It also replicates along the way. What ends up happening where you end up with a severe outcome is called a bilateral pneumonia. And as a word of kind of a caveat, I am an environmental engineer by training and now do environmental health. So if I talk about a medical term but don't exactly pronounce it properly, I'm an engineer. So that's my excuse on that one. It's commonly termed as a double lung pneumonia, so both lungs end up getting impacted by it. And what a pneumonia is the fluid buildup in the lungs due to the body's immune response to the infection coming through. The period in which we have development of the infection is an interestingly broad period of time. It's up to 14 days. It can be for symptoms to be onset, which is a really quite a long period of time. So that's part of what could be driving the transmission. This was taken from the probably very well-known Hopkins map at this point. Took this yesterday, so it doesn't capture what we've seen so far in the latest update from Governor DeWine and Dr. Acton with regards to what's going on in the state right now. But what we can see is this is widespread throughout the country. There isn't a state that hasn't been impacted by it at this point, and I think all but one territory has also been impacted too. I'll double check that at some point. So that's where we're basically seeing it. Ohio, we're seeing it just like we are seeing it throughout the rest of the nation, clustered in more densely populated areas. but that's not overly surprising from any infectious disease standpoint to an extent. And for a viral respiratory disease like this one, again, it's not an overt surprise with regards to population density being a component in what we're seeing. So what we also need to do by way of a piece of clarification is the difference between SARS-CoV-2 and COVID-19. So there really isn't a difference. You need SARS-CoV-2 to cause COVID-19. And it is as simple as it sounds when you say it like that. But the important distinction is the types of models that we're going to be talking about in this webinar in particular. So the predictive models that we're going to have a very brief discussion over that you've heard in the news, both the Ohio, the one that's been talked about in the Ohio briefings, as well as the national one that's been talked about more often as well. Those are tracking the disease. They're trying to predict the disease transmission. The models that I'll be talking about later on in the latter part of the webinar, what we're trying to do is we're trying to track the virus transmission. How is the virus surviving and moving around? And so often there is a conflation between hazard and risk, or hazard and outcome. And this happens really quite often. So the left image you're looking at here, I can actually show you with my mouse. This one is from Wikipedia, and this one is actually from military medical, I think the Army Medical Division. And you can see there's this very easy way of conflating the disease with the pathogen that happens quite often. But there is an important distinction between the two. When we're talking on the modeling side of things, sorry. When we're talking about what we're actually seeing in Ohio, and again, these are numbers from yesterday, overall, we're seeing a fairly clear delineation based on the severity of outcome, right? So what we're seeing is a fairly interesting spread by way of age ranges that are being listed as a case count. Now, there are some issues with regards to how cases are being tracked. Everybody's probably heard in the news about testing kits not being available, some testing kits not working initially, things like that. That all ends up becoming what can be called a sampling bias. The bias being on, because of how the test kits have to be approved for use, what we're really capturing are the moderate to severe illnesses to be able to qualify for having a testing kit. So there's a bit of a sampling bias with regards to what these numbers end up looking like, but if we look at the severity of outcome, we really are seeing what we see everywhere else, which is predominantly older age groups are at a much higher risk for severe outcomes and conditions. So that's some of what we're seeing. And then there's two predictive epidemiological models that we can talk about in a general context, because everybody's heard them, everybody's seen them so far to date. So the first one is the IHME, the Institute for Health Metrics and Evaluation, out of the University of Washington. Very good group, good track record on epidemiology and predictive analytics. Now, they differ from basically all the other models that are operating right now, all the other predictive epidemiological models, including the one from Ohio State, which has been integrated into the briefings at the state level. But what we're basically, the main distinction is that IHME starts from tracking the number of deaths reported as opposed to tracking the number of cases reported. So that has a different type of sampling bias to the sampling bias we already mentioned with regards to the testing kits. The sampling bias in this instance is there's inconsistency in the reporting of deaths related to COVID-19. There is some more anecdotal, but it's becoming more common for reports of mixtures of possible deaths. So they might have, the patient might have died of something else, but they also had COVID, so it's listed as a COVID death. So there's a sampling bias related to their data as well. So there's no set of data that's going to be free of sampling bias. But we have one that is based on that, and then they go from there and optimize a statistical model for calculating based on this number of deaths, how many beds would be needed based on this number of deaths that we have seen in a particular population. So what ends up happening is a statistical model gets optimized kind of in a reverse direction with regards to this model. And then the other model, and what we're showing here is I'm showing what's available on the ODH dashboard, which is a great tool if you want to be able to look at everything and you're a data nerd like modelers like me, then you're really going to be quite interested to see how the trends are laying out, where the peak is and how it's shifting around. And again, there can be a lot of different back and forth when you're talking about different modeling methods, different input data, all of these different things. And the devil always is in the detail when you're talking about any kind of modeling. The main take home is that because Ohio acted quickly, acted assertively with regards to trying to flatten the curve as much as possible, as early as possible, it looks as though we have actually done that quite effectively. Now, two things about that. One is that this is a very rare moment for public health in a general sense, in that this is a very fast-moving respiratory virus that has impacted the entire world. So there's that aspect of it. The other aspect of it is the level at which we have used social distancing on a global scale to try and address this is an interesting historical moment, and the level of impact that we are self-inducing on economic output is also a unique moment in history as well as public health history. So we're seeing a lot of impact on what happened to that curve, but what we have to understand is that vigilance is a key to this, is that we're not sliding down a peak. What we're now doing is we are riding out a bit of a plateau, and we want that plateau to start now curving downward to less and less and less cases, which means that we need to maintain social distancing for some period of time. And now what's happening is discussions on how do we try and move out of the social distancing, but it would have to be a metered or a staged kind of approach probably to be able to make sure that we don't end up risking another peak just by what we're doing. So before we have a ton of questions that come through about which one is correct, a quick primer into mathematical modeling, and this will help a bit with what we're going to talk about with regards to the other modeling that's going on with trying to figure out what happens next. What do we do now? So when you're asking about it, which one is the correct model, you really can't answer that. And the problem is, especially when we're talking about predictive analytics or predictive modeling in a viral pandemic or any kind of pandemic, is twofold. One is the massive scale at which that you're talking about. You're trying to have any kind of model work for an entire country or an entire state, which is going to send its own uncertainties into your model. The other thing that you're going to run into when you are trying to do this is, especially in this case, is that this is a novel virus. And when we say novel virus, we mean it in the very simple sense of not only have our bodies as humans not encountered this before, which is why we don't have an innate immunity against it, but that also means is that we don't have any models for this virus. We have models for similar viruses or other coronaviruses, but it doesn't mean that they would work, and it certainly doesn't mean that they would work at the scale at which this has occurred at this level. So that's why one of the main reasons you really can't say it's correct. The other aspect of it is that in mathematical modeling, you have the pure mathematics side of things, which is trying to find truth. But it's not really what you're doing with the mathematical model. What you're trying to do is you're trying to have a computational system or a computational description of the real world that is as accurate or precise to what is happening in the real world as possible. And so what ends up happening when you have any kind of modeling team or model being approached is was encapsulated perfectly by Dr. Bricks on the White House Task Force. All modelers have their preferred functions, and all modelers have their preferred data. And that really is what it comes down to. So you want to make as accurate of a prediction as possible. You need to be able to understand what the limitations of the model and the data are, and then you need to move beyond and through that. Now, what we think about when we're talking about predictive epidemiological modeling and predictive mechanistic modeling, there's a difference between the two, is that in both cases, you have messy data that you need to deal with. So mechanistic modeling is what we're going to talk about next. That one, you're dealing with a lot of environmental data. Environmental data has its own unique sampling biases, uncertainties, and variabilities that are going to make its own set of limitations. And then trying to extrapolate that up and into something that would be able to be used at a population level has its next set of challenges once you start to scale up from that. So that's basically what you want to try and remember, is that when you hear arguments about, is this model correct, is that model correct, it's not always the best way of trying to think about it. The best way of trying to think about it is, how realistic is this model to the real world? How much fidelity to the real world does this model maintain moving it forward? So what happens when we reopen is a really massive question. I am not engaged with trying to do that on the predictive epidemiology side of the response team. Where I split off on the response team was to look at mechanistic modeling and model what's happening to the virus itself. What basically this falls under is a key question. How can we understand more about the systems we create to provide health sustainability and health resiliency? Basically, the systems that we reside within, be that a school, a office building, or a kitchen, all are going to have their own unique ways that we can be exposed to multiple different pathogens or chemical hazards throughout a day. SARS-CoV-2 is no different in this. It just has its own unique pathways to be able to get to us. So that means that what we want to do is we want to develop modeling methods so that we have better tools for making decisions under uncertainty. So in a way, what we'll talk about is the types of modeling groups that we have had on Ohio State campus really allowed us the ability to be able to be a forefront group in developing out the predictive epidemiological model, and then also be a forefront group in trying to do some of these what-if scenarios with regards to how do we reopen things, because what we're doing on a mechanistic level is essentially what's in your pipes. Yes, that's in your pipes. Maybe not that bad. How does that impact what gets into the air, what deposits onto healthcare surfaces, what deposits onto a healthcare worker's hands, and then eventually onto you, to themselves, to their family members, and so on from there. And how do we do this within overall systems? How do we understand what the system is doing? So what we want to do is we want to focus on the virus in these instances. This is not the begin and end all of mechanistic infectious disease modeling. There are other flavors, there are other types, but remember, in Dr. Birx's words, every modeler has a preferred function and preferred data. The type of modeling that we do in in our lab doesn't pin itself too much to a particular function or a data source, but we still have our limitations on what we can do. So basically, think about it this way, and I'm going to give the example of how a virus, SARS-CoV-2 or any other virus or bacteria, would transmit within a healthcare environment. You have a lot of different surfaces that are going to be interacted with, either be with the patient themselves, so the patient is going to contaminate some of the surfaces. If the patient is coughing and aerosolizing the SARS-CoV-2 into the air, it's going to be able to deposit on different surfaces as well. Once you intubate someone, there's an aerosol that sometimes will get produced. Because of that, so the actual procedures themselves can create an aerosol, the patient themselves can create an aerosol, and that's going to be able to spread and land on different surfaces. And then we know all very well, don't touch your face. That is a very good way of making sure that you stay protected. But we also have to figure out what's happening with regards to the aerosol. So what we have are systems in place so that we can model what ends up getting onto a person's hands. How does that get impacted about whether or not they wash their hands, how they wash their hands, what they wash their hands with. All of these have different impacts on whether or not the virus will be removed and whether or not the virus will actually still be alive on your hand for you to be able to give yourself a live virus and then eventually become infected. And then how does this end up impacting other devices that are being used with the patient, on the patient, near the patient. So we have different IV units that can be interacted with, computer systems. There's a whole lot of different surfaces that can allow for movement of the virus itself. So the way we do this, so where we don't completely lose our minds, is we have a set paradigm to be able to move through, and this is called quantitative microbial risk analysis. There are a lot of different types of mechanistic models, but what we do is we try to model three main domains. Pathogenesis is what happens inside the person. So once a virus comes into you, there is some probability that that one virus or a set of them, up to 100, 200, however many aggregated viral particles are needed to initiate some kind of an infection. So we can model that within a particular area called dose response modeling. Then we have so that would be the in-host or pathogenesis domain. And then we have a pathogen human environment domain. So the pathogen needs to stay alive. The pathogen needs to be in an environmental matrix that's able for a human to interact with it. And then that human needs to take what's on their hand and then put it onto their face or inhale whatever might be in a close enough proximity for the aerosol to be able to impact them. And that gets housed in the physiological modeling within exposure modeling. So we'll model how a person interacts within a room, how different surfaces are being contaminated, how the virus is surviving on those surfaces, can we disinfect it, how well do we disinfect it, things like that. And then we have externalized pressures, such as we need to reopen the state. There is an economic need to be able to reopen the state. But if you do it too quickly, you can allow for the virus to transmit through a population very quickly again. If you allow that to happen again, you could have spot outbreaks that could lead towards another peak. So we need to balance all of these domains. And what we need to do is we need to be able to take these things into account in an overall modeling system. So what we see is what we're doing in regards to how we're building our models with bioaerosol contact, bioaerosol interaction, hand to fomite to face interaction, having some kind of close familial contact with the infected person, and there are a couple other vectors. You can have it where a person or a child goes to school. There's a number of children who are asymptomatically shedding. It gets on their clothing comes back home, and the parents are now exposed. Because in the child age groups, what we're typically seeing are mild or asymptomatic infections. So that's where we can start looking at how these bits move around. Now, you've heard back and forth about aerosols. This is a really good video that came out of a collaborative in the Netherlands that is giving you an idea of being able to contextualize what's happening with a bioaerosol. When you cough or sneeze something out, it has a certain amount of mass. Because it has a certain amount of mass, it's going to fall out from the air at either a rapid or a slower pace or a slower speed. That is governed by how big the aerosol is, how high the humidity is, what the temperature is. There's a lot of different factors governing this, but what we can see is simple interaction, such as being far enough away, means that the person is contaminating themselves, or if you stagger your approach for how you're walking next to someone, running next to someone, then you're going to be able to have another layer of protection over this. So bioaerosols are a complex field, and they're something that really are showing themselves to be very important for SARS-CoV-2 transmission and COVID-19. So 2 examples of what we're building right now. We have one group. So we have, as part of the IDI response team, we have 3 independent, somewhat independent, I'm kind of managing them, risk modeling groups. One that's looking at schools and similar gatherings, focusing mainly on schools. The other one is on healthcare associated transmission, mostly for the healthcare worker safety. And the other one is on disinfection targets for multiple other locations. So that's what we're building right now. The first example that we'll go through is on the schools. So you don't need to go through and make a note of everything that's in here. Basically, this is setting up the context for the simulation that we're going to show in a moment. If you look at the 2 main things to look at, one is the map here. So we have kind of a central learning area that we typically see in elementary schools. And then we'll have over here that I'm not showing, sorry about that, is a walled off cabinet area, kind of where children would put their coats and their bags and everything else like that. And then we have a door here. There's a number of different outlets, 4 different outlets for this room for evacuating air out. The diameter of the particle is 0.5 microns here, 4 microns here, and 0.7 microns. The important part of that is to be able to see how the different size aerosols move around, so you can get a sense for why we model things that we do. And also you have this cone of spread. So once you cough or sneeze or say a letter like P, you have a certain amount of aerosols that come out and they take a certain pattern. And we try to model that as closely as possible. This is one of the mechanisms that we put into a mechanistic model. How close can we get to simulating exactly what happens in the real world? So the idea behind this is that we have each one of these groups. So we have this child, 0.5 microns, 0.7 microns, and 4 microns and 0.7 microns for the adult here. The adult stands taller than the other 2 students, and what we can do is we can simulate this through. So we have our first cough that comes out, and that cough that comes out starts the spread moving forward. And what ends up happening is it spreads really quite rapidly. If you maintain a high high ventilation rate within a room, you can actually move the viruses in the bioaerosols at a more rapid pace. It'll mix that a little bit faster, but what you're also doing is you're evacuating the air as well. So you can see what ends up happening is it ends up being a fairly even spread of the viruses throughout the room. And what we're seeing is both viruses in the air as well as viruses that are depositing on different surfaces. Now, this is where what we'll do is we'll take this and we'll say, what are those surfaces? What are the touch frequencies that children would have for some of those surfaces, such as the toys, the books, the tables, the chairs, things like that. Each of those has a different frequency of contact, and each of those are made of a different surface material. So you've probably heard already about how long SARS-CoV-2 lasts on plastic versus metal. The same basic thing applies with regards to how you transfer it from that material to your hand. Metal is very easy to transfer to your hand. Cardboard is more difficult to transfer to your hand, which is why in the blog post I did for Wexner Medical School, I advised against washing your groceries and all of the other different packaging that comes with them, unless that is something that helps alleviate stress for you, something that allows you to be able to manage the stress of this pandemic better, then that's something that you can actively do, so long as you do it safely and you're not ingesting harmful chemicals in the process. So this is an idea of where we're going with this. Now, this model in particular isn't as far developed as the healthcare associated transmission one, which is, I'll go into a little bit more details with that. But once we have contaminated surfaces, we can have the children and the teachers interact with those surfaces, create more or less, track where on them is contaminated, how much are their clothing and their backpacks contaminated, and then they bring all of that home. And then again, what we have is fomites on the children. Their clothing or surfaces, any surface, any inanimate surface that can harbor a pathogen, we call a fomite. So any of those surfaces, like their clothing, their backpack, or other materials, they're going to end up being able to spread the virus beyond there. So that's one of the ways that we're trying to look at it with regards to reopening schools and other venues. But then the other one that has a little bit more development is healthcare associated transmission. So now, like I said, it was an interesting benefit that the teams that we do have at The Ohio State University, we do have here. So before the pandemic became a pandemic, so we submitted this proposal in February. What we did was we got together a group of mechanistic risk modelers, infectious disease doctors at Wexner, at Banner Healthcare System at University of Arizona, and in University of Leeds. We also have CFD, computational fluid dynamics modelers, so that box that you saw with the viruses spreading around through the room, that's a computational fluid dynamic model. So CFD modelers from the University of Leeds and microbiologists from the University of Arizona, as well as the Ohio State University, to put together a healthcare associated risk and epidemiology combined modeling system. So we already have this basic idea in place of how we would build the models and move forward from there. So this was the most rapid model for us to build going forward. Doesn't take away the Herculean task that the CFD modelers at University of Leeds and colleagues at University of Arizona worked with us on how to build this out in such a short frame of time. But the idea is instead of a healthcare associated infection, an HAI incident happening, and then trying to learn a lesson and adjust policy from there, the idea of what we're trying to build is say we will model all of the possible mistakes that we can think of, and all the different what if scenarios of what could happen to reduce or possibly unintentionally exacerbate an HAI problem, and then update the models based on any failures along the way. So if an HAI happens, teach the model where it failed and then move on and improve itself. So what we've been able to do, and we started with some CFD models that we had built. What you're seeing is a CFD model that was built for a surgical unit. So you have a positive pressure area here to be able to maintain a safe and clean airspace over the patient. And then you have people operating on the patient, and you have somebody here who is possibly contaminating the clean airspace, right? So this one is a little bit much for a webinar to be able to see the video. So what we just have is we have some stills of this, and there's a line drawn down here somehow. But what we have is what we can do is all of these streamlines, think of them as portions of a bioaerosol moving through the room. You can see how equipment can become contaminated. You can see how something can spread. So we do this for patient rooms individually. So we have an example on the left, that's actually for Clostridium difficile, as an example to show you some of what we have already built out. And on the right is something similar to what we'll see in the output of model on the next slide. When we're talking about it, what we wanted this model to be is there was a whole set of different scenarios that we could run. The first one that we had as a yes, we definitely want that from Wexner. Wexner Medical Center was, what is a safe shift? So basically, what is the risk that you get over a cumulative shift on visiting multiple patient rooms throughout that shift? So it gives you an idea of what we're trying to model. So where we started from was a baseline mechanistic risk model that's you're seeing on the bar charts on the left. And what that was allowing us to do is allowing us to say, well, if we're trying to reduce the risk to the patient of, in this case, a C. diff infection on this example, then what we might want to do is we might want to say, well, we have the ability to alter the decontamination capabilities or how the patient is interacting with them, and gives us an idea of what we can do to try and maintain what's going on in the system. What you're seeing on the right is a stochastic model. So a stochastic model is a model that takes into account random processes, where what we have is a stochastic model that's been trained on data from multiple healthcare workers in the University of Leeds system, which is where we have this data for. And then how does that healthcare worker move through the room and have different contacts with different surfaces along the way? So the patient, anything around the patient, hand hygiene areas, things like that. So when they're doing their rounds, when they're operating on the IV, and then any other observations that they have going on at that time. See if I can get rid of this thing. Nope. What this allows us to do is allows us to say, based on how the healthcare worker is moving through the room, contacting different surfaces, and based on what we know from the CFD model, how those surfaces have been contaminated by what concentration of viruses, we can say for one visit into the room, so 4 cycles within the rooms, 4 different things that they needed to do in the room per visit, these are what the risks are to a healthcare worker. So what we can do next is we can aggregate this over multiple rooms in a shift, multiple patients in a room, if that's where we're at, and any number of other scenarios. So the scenarios that you're seeing here is just one room. You have whether or not they use ethanol on the glove before doffing it. That's an option that can be used. And just a regular glove change in and of itself. What you're possibly seeing between these two is some of the data that we have seen is that there's this possibility, and we don't know for sure, there's this possibility that after having done an ethanol rub on the gloves, that proper doffing procedure isn't followed as much. And then not doing anything where you don't encourage a appropriate hand hygiene protocol, as well as appropriate glove doffing. So removing PPE is called doffing. Then you have a much different risk. Now, some of the concerns that come through from this is that we're seeing really very low risk, but aggregate that over 4 to 8 rooms or 4 to 12 rooms on a shift, have that shift last for 8 to 12 hours, and have that run for a number of days. So we know what it's going to be for Wexner's planning, but in other hospital systems, it may end up being different. It could be a very long shift over many days, and that this risks will start aggregating and building on each other to something that may not be acceptable. The other thing to watch and think about is 1 times 10 to the negative 5 is what we set as an acceptable risk by EPA standards for drinking water quality. So we've already established certain acceptable risks, and it's an outlier, but we're already hitting some of those with some of our estimates. So we can see that healthcare worker safety is a vital concern, and what we're going to do from here is get an understanding what is a safe shift, what kind of PPE management is necessary, and then move it from there. So a couple of things, I jotted these down. In the Sustainability Institute, we recently had a meeting where we discussed a whole list of different research foci that might be possible at the end of this. And I just thought I'd list a couple of them so that the general ideas the general ideas are somewhat obvious when you really start looking at them themselves. The idea of sustainability and resiliency having to be hand in hand is something that in my mind as a researcher, is fairly obvious. Then again, I am a little biased on the resiliency side of things for what I do. And I'm getting close to when I should just stop and let questions come through. But these are some of the other research topics that we were discussing, understanding more about supply chains, how to make them more sustainable and resilient, or not lose the environmental sustainability gains that we have made and make more resilient systems as well. Sometimes we think about these things as being at odds with each other, when what we should probably be thinking about is how complementary they are with each other, to be able to make sure that we maintain both sustainability and resiliency moving forward. So with that, I'll open things up for questions. I have my contact information here and at the very first slide, if you took a note of it, and be glad to entertain questions.
Mark, thanks. That was great. We appreciate it. And again, for those of you that might think of some questions later, Mark's email address is on this slide, and I encourage you to go ahead and write it down and reach out to him. I'm sure he'd be able to answer questions that you might have. So Mark, as I was monitoring the chat, and we got a lot of great questions, Michael Oglesby fielded a couple of them for you, so you know you got a wingman here out in the process. But the questions that came in, I kind of feel they fell into 2 categories. One was a set of questions that were asking about the reliability of the models themselves. And then the other set of questions was, you know, what are the models suggesting, what we should be expecting in the months ahead? So let me start with a question for you in terms of the reliability of the models. And there's 2 that I'm going to go ahead and just kind of condense and put together. Those questions are, will there be a post-pandemic review of the models to see which ones work the best in terms of the predictions? And related to that, based on the data we have so far, which models do you think have been the most accurate?
So the first one is fairly easy to answer, and I can't be the only faculty member who is encouraging a student to volunteer to do that analysis for comparing the different models. There are a lot of different models to be able to compare. You have drastic overestimated models, like what were originally being talked about by Imperial College. Not to take anything away from Imperial College's SIR capabilities, they basically invented it. But they were obviously really quite off. So there will probably be multiple projects that will push that forward to be able to try and do that. The challenge will be, one, ensuring that you operate the model appropriately. Every model has to be run in either MATLAB or R or Python or something in order to actually operate, especially the ones that are more adaptive to the realities of a system, like complex networks of people interacting with each other, optimization of different functions, things like that. Excel can do some stuff, but it can't really get it stretched that far. So that's going to be a bit of a challenge. The other challenge will then also be addressing them under all agreed upon statistical methods for comparison. And if you really want to see a big fight, get a number of different statistical modelers into a room and have them agree on one specific method to use. So that'll be in and of itself a challenge. It has to be done by way of being able to say, if there's when there's a resurgence of SARS-CoV-2, or 20, 30, 50, 100 years down the line, and there's another global pandemic, which one has hopefully been advanced since now, would you use? With regards to, basically the other question was accuracy, which one is more accurate? That is going to have to be answered once we have a much better understanding and agreed upon definition of a case or a fatality. So right now there's too much sampling bias in either the testing results or the mortality statistics for us to be able to say this model is more accurate than that model, or this model is better than that model. It's very similar to the slide I had about which one is correct. Right now, in the throes of our response to the Ohio epidemic, the US epidemics, and the pandemic in general, we can't answer that question. We will probably be able to answer that question months from now, once we have an ability to have an agreed upon case definition, organize the data better, and then proceed from there. This is not any different than any other pandemic or large scale epidemic. So the SARS-CoV-1, the original SARS epidemics, it was months afterwards when we understood the actual case fatality rate or the actual infection rate fatality rate. It always ends up dropping downward once you understand more about how many people actually had this and either had mild symptoms and thought it was just a cold, or were asymptomatic, because they're all going to go into the main denominator of how you calculate what those rates were. So all of our statistics and understanding of this are going to change for us to be able to say which one is more accurate or better to use. So patience on that is what I would urge.
Sure, and it's true. I mean, you know, government agencies all the time update the different types of statistics they put out, you know, when they get better data, and so they're always constantly improving it. And obviously, you'd want to use the best data that you can have to see how accurate the models were predicting that. Well, speaking of predictions or projections, I should say, we got a couple of questions related to what you see the models pointing to in the near future. One of the questions is, how many Ohioans can we expect to become infected? And what evidence do you have to suggest that this will peak and recede within the next few months?
So two ways, those have to be addressed in two different ways. And I know it can be very frustrating when you ask a modeler or an academic or a researcher a question and then we give you a non-answer answer. But really the problem ends up being is there's too much uncertainty. What the way to think of uncertainty is a combined lack of knowledge and data. So there's two main things that will impact any kind of prediction, statistic, or model. There's variability and there's uncertainty. Variability is, you know the mechanism, you know what's there, you just don't know how much is there. You don't know how much of the mechanism is impacting things. And so that's your variability. Your uncertainty is, you're not sure what the mechanism is, you're not sure what the susceptible rate is, and you don't know what that value is at the same time. So that's where the difference between those two goes. it's a quote I use all the time when I teach uncertainty in my classes, and it's from Donald Rumsfeld, which is there's known knowns, known unknowns, and unknown unknowns. It's a perfect description of how you scale uncertainty moving forward. Right now, there's too much uncertainty in both the sampling data as well as the other statistics for us to be able to say exactly how many. We have the best estimates that we can move forward, and I would encourage you to go to the ODH dashboard because those get updated on a more consistent basis. So what I tell you right now, because I don't have it right in front of me, will not be what that next prediction is, because we're learning. The models are all learning as they go along. It's not a static y equals mx plus b kind of equation. They learn as more data comes in. So they're going to be updated, and just keep track of how they get updated, but we are seeing those estimates kind of trend downwards. What we are seeing overall is probably a plateau. So you go up a curve and then you plateau and then you start going down a curve. So that kind of up and then straight back down, that's, I mean, like, just think of it as a road. Nobody designs a road that way. And so an epidemiological curve in that kind of a spike is odd. So what's happening, typically what we're seeing, and this is consistent through a number of different outbreaks, is it would lag forward, exponentially increase, and then once it's at that exponential increase, it'll either continue or it'll start to plateau. And then once it plateaus, it'll run for a little bit, and then it'll start curving back downward. We're on a plateau now. So as we're plateauing, now what we need to ask is, the critical question right now is, are we plateauing with an upward trend, or are we plateauing with a flat trend, or are we plateauing with a downward trend? If we're plateauing with an upward trend, we most certainly have to maintain social distancing so that that upward trend plateau does not turn into another spike. If we're flat, then we need to maintain for a little while until what we can do is start going down on a downward trend plateau. And then once we're on a downward trend plateau, we have more options for being able to move things forward. That's pretty much the best I would be able to give you by way of an estimate of number of people, other than go to the ODH dashboard. So the ODH website keeps getting updated, and one of them is the ODH dashboard. Great wealth of information to be able to use on that. If you prefer the IHME model, go to the University of Washington's IHME webpage, and then you can choose Ohio and look at that. So there's a number of different options for you to be able to choose to find that information.
So Mark, I appreciate you bringing up the Donald Rumsfeld quote. That was one of my favorite things to come out of the Bush administration. So thanks for bringing that up. You know, but something similar to that, and that is, you know, oftentimes, you know, when there's a crisis that's averted, people don't really see how bad it could have gotten, see what the costs are. Maybe they're making the sacrifice to avert the crisis. They're feeling that sacrifice, yet they're not necessarily seeing the benefits, or they're not necessarily seeing how bad it could have gotten, because we are flattening the curve. And on that note, there's a question here about, have we over flattened? You know, hospitals are empty, deaths are below a mild flu year. As I'm reading the question here, if not enough people have been infected, asymptomatic or not, how do we avoid an overreaction, especially if there is another wave to come, and then people don't go into the same social distancing practices because, you know, they're not convinced how effective they were.
So that's a really good question. And what we can probably do is we can look to a number of different cases that are already happening. So today or yesterday, I think it was today, Denmark is loosening their restrictions. So children are going back to school in Denmark this week. I think it actually started today. And they had more of a lockdown than Sweden and the Netherlands did, but they didn't go as full-fledged as Ohio and other places have. So you can see kind of a mixture approach there. But you have to maintain another light or another concept of cultural differences. In Scandinavian countries, there's a different type of culture with regards to listening to and believing governmental and non-governmental scientists on opinions, recommendations, and things like that. There's also a different approach to following different guidelines. Now, Ohio and America has done an amazing job on our compliance rate. Our compliance rate is incredibly high for almost any other type of compliance assessment I've ever done for drinking water or technologies or anything like that. And so I am really quite impressed and applaud Ohioans in general for doing what they did. But we really can't answer that question very well. It's basically trying to prove a negative. How many people didn't get sick because of this? We can't answer that. And we run into this quite often with the type of models that I build, even on specific contracts, which is, well, how much money are you going to save me? I can't really answer that for you because there's a number of different ways in which you could have prevented an infection from happening. The main thing is that the responses that we put in place showed that social distancing is a very viable option for us to be able to address a fast-moving aggressive virus like this one. What it also is showing to us is, I'm not sure if we have over flattened the curve as much as now we need to make very rational, educated decisions on how to move forward. Moving forward with increased testing capacity, moving forward with increased monitoring and analysis. Like, how do we ensure that as we open things up, we don't have another spike that occurs? Every epidemic ends up having other smaller outbreaks that will occur because you restrict or loosen restrictions. And every pandemic has had some kind of resurgence or some type of recurrence of the disease. Sometimes it's similar, usually it's a little bit less. And so to an extent, there is a very high possibility that no matter what we do, there would be a resurgence or a recurrence of SARS-CoV-2, probably not at the level that we were expecting to see from what was moving forward. So again, it's kind of a non-answer, and it mostly is coming down to we really don't know. We've never done this level of mass social distancing as widespread as we have throughout the nation. We have never shut down our economy for a period of time for a public health emergency. And this particular type of virus, how it can stay asymptomatic for as long as it can, from as much as we know about it, as well as how it spreads, is also a rarity. There are a lot of historical moments that are occurring all at the same time, which means making any kind of prediction is going to be that much more difficult. So
Okay.
Hopefully that answers it to an extent.
You anticipated the final question I was going to ask you, which is, do you think we're going to see the Buckeyes play this fall? Are we going to be able to get people back in the stadium or not?
That actually kind of gets to the second to last slide that I had on what are we defining as a new normal, as well as what is business as usual after all of this. I think we're probably going to end up seeing the Buckeyes playing in the autumn. Viruses that are spread by these kind of bioaerosols, there are a lot of physics as to why they occur more often in the winter. So if there is a possible resurgence, that could be about when it would come through, but we don't know. That's a really big thing to say. We don't know. So I'm optimistic to say that we're going to watch the Buckeyes playing. We may not have shoulder-to-shoulder capacity in the stadium, but I'm an introvert anyway, so I never minded that idea. So, maybe not at the level. People may have learned a lesson or not learned a lesson, but have decided to practice some level of their own kind of social distancing moving forward. But I'm optimistic to say that we'll watch them play.
Well, thanks, Mark. I appreciate it. Appreciate your optimism. Yeah, I guess we're going to need a bigger stadium. Maybe that's the answer.
Yeah, I think that the infrastructure planning would be.
There you go. Well, thanks for sharing these insights with us. I think we're all eager to have social distancing end safely, and some of the factors that you shared are helpful for us to understand what goes into making those decisions. For those of you who are participating today, thank you so much for making the time to join us on behalf of the College of Public Health, the Infectious Diseases Institute, and the Sustainability Institute at Ohio State. We're so glad you could join us. Mark's email's on that last slide. If you have any follow-up questions, don't hesitate to reach out. And before we close, I want to let everybody know Ohio State is holding a very special virtual celebration of Earth Day this Wednesday at 4 p.m. If you'd like to join us, please go to epn.osu.edu. That's epn.osu.edu to register. Thanks again. Please stay safe out there and have a good evening. Bye-bye.